It's my pleasure to introduce next speaker, Dr. Mike Baine from Department of Radiation Oncology, UNMC. He's assistant professor of radiation oncology. His topic today is prognostic ability of advanced radiomics analysis and prostate adenocarcinoma. Dr. Baine.
Thank you, Dr. Zen, for the introduction, and thank you heartily to Dr. Boyle and Dr. Dan Zhang, who ended up setting the stage very well for my presentation. Ends up making my job a whole lot easier here. As Dan ended up going through, oh, so sorry, first off, I don't have any conflicts of interest. This is just an introduction or outline to what I was going to talk about, but I can actually get rid of the introduction portion since Dan ended up going through that very well. So we'll basically be talking about what the promises of radiomics, specifically in prostate cancer, and then very briefly go through what current data is out there. And it looks like this is actually an older version of my PowerPoint, but either way, I'll be able to skip some slides. I actually ended up taking out a good portion of the stuff that we are doing with our work because we don't actually have any data to show yet. And then we'll be talking about unanswered questions currently with regards to prostate cancer radiomics, and then the concerns that we have based on the current data that is out there. So I can skip through all of that and go directly to what is the potential utility of radiomics in prostate cancer. And basically, I think you can end up breaking this down into two different categories. The first is basically improved prediction. And it's really, can we use radiomics to better predict beyond what we see with PIRADS, whether or not something that we see on MRI is a clinically significant lesion. If you think back to one of Dr. Boyle's slides, even in those that ended up having high risk PIRADS lesions, only about 60% of them actually have high risk disease. Well, that's obviously better than what we end up seeing if we just do blind biopsies. I think that can be significantly improved. This obviously has very obvious implications with regards to patients on active surveillance, those where we're trying to weigh whether or not it's worthwhile doing a biopsy, and then ultimately ends up giving us easier assessment of hard to biopsy lesions, things more on the anterior portion of the gland that are harder to get to with a needle. And then the second category is prognostication. So what ends up happening with these patients after we treat them? Is there something that we can do with radiomics that helps to predict that, which itself can have implications on possibly what treatment to choose, or ultimately whether or not to choose treatment at all. So with regards to current data, at last search, and admittedly this was about a week and a half ago, but at last search there were 118 publications looking at radiomics and prostate cancer. The very first one came out in 2015, and since that time, the interest in radiomics and prostate cancer has increased exponentially. For example, there have been greater than 40 publications looking at radiomics and prostate cancer from this year alone. In reality, these 118 publications can be broken down into kind of three main categories. The first is detecting clinically significant versus insignificant disease. The second is predicting treatment outcomes, and then the third is trying to improve accuracy of imaging-based tumor staging. So first, let's go into detecting clinically significant disease. This is where the lion's share of the data currently resides for radiomics. And I'm just going to talk about three representative publications. So here's one by Zhang et al. That was published in Frontiers in Oncology back in June of this year. And basically what they ended up doing is they tried to see whether or not some radiomic signature could end up improving the prediction of whether or not something was clinically significant prostate cancer over PIRADS alone. And basically what they ended up seeing, as you can see here, that the area under the ROC curve for PIRADS lesions ended up being only about 0.69. Or sorry, it was for radium, or no, yeah, it ended up being 0.69 for the PIRADS lesions. If you ended up doing radiomics alone, you can get the AUC up to 0.81. If you ended up combining the two together, you could go up to 0.84. So point being is radiomics is, at least in their model, significantly better than PIRADS alone at predicting clinically significant versus insignificant prostate cancer. Now, this next study basically ended up using radiomics extraction from ADC imaging. I apologize. So again, this is an old version of my PowerPoint, so I'm going to be skipping some slides here. This one ended up doing segmentation from ADC and T2 MRIs. And what they did is they ended up combining radiomics analysis with these two imaging sequences, and then actually combined it together with a series of other things such as PIRADS score, mean ADC, PSA density, and then DRE findings, and put this into a large combined, basically decision-making tool, and then compared it to PIRADS alone. Again, trying to see whether it was better than PIRADS alone at actually determining whether or not something was clinically significant. So meaning having a Gleason score of 7 or higher is how they defined it. What they found is that the combined decision-making tool was definitely better than PIRADS alone. Now, the one significant issue I have with this study as they did it is that they didn't actually look at the combined model without the radiomics features. So we don't know how much the radiomics features actually end up adding to what we normally have clinically with DRE, mean ADC, PSA density, et cetera. And then the third representative publication ended up actually looking to see how likely it was that PIRADS could end up predicting if the PSA that we found at radical prostatectomy was actually higher, or sorry, the Gleason score at radical prostatectomy was higher than it was based on what we knew from biopsy alone. For this, they ended up looking at T2-weighted MRIs, ADC, and DCE sequences. And basically what they ended up finding is that a radiomics signature ended up having an area under the ROC curve of 0.87, whereas if you ended up just looking at clinical features that were available at the time of diagnosis, so the T-stage percent positive cores, Gleason score, PSA age, and then PIRAD status, those themselves actually only predicted the likelihood that the PSA was going to, or that the Gleason score, sorry, was going to be higher than what we knew on biopsy with an AUC of 0.65. So again, point being is that radiomics features do significantly improve our ability to predict what the actual pathology is of these patients. So now going into predicting treatment outcomes. This is something that is less well studied, but it definitely has been looked into. It's mostly just assessing likelihood of biochemical failure. And it has been looked at both after radiation therapy and radical prostatectomy. So here's one looking at just patients who ended up having radiation therapy after a period of neoadjuvant adjuvant deprivation. And then these patients were followed for biochemical failure. And of the patient population studied, 32% ended up having biochemical failure after their radiation therapy. Now, if you think about this, the people who have biochemical failure are likely inherently going to have higher risk disease, and they did not balance these at all for these patients. But what they were able to find is that if you ended up doing a radiomics analysis of the whole gland, that you could actually end up giving a reasonable prediction of who's going to have biochemical failure and who's not. The way that they actually did is they looked at all the patients who had biochemical failure, and they found a radiomic signature where half of the patients with biochemical failure had that signature, the other half did not. But those that did not have biochemical failure, 86% of them did not have this biochemical signature or this radiomic signature. And then for radical prostatectomy, this study that came out in March of this year ended up extracting features from diagnostic MRIs, looking at T2-weighted and ADC sequences. And then these patients ended up undergoing radical prostatectomy, and then again were followed for biochemical failure. And what they found is that of the 27 patients who ended up undergoing biochemical failure, a radiomics model was able to predict their biochemical failure with an accuracy of 76%. So again, could be quite useful. And then lastly, as far as predicting stage go, most of the studies that have looked at trying to improve stage prediction based on MRI are really looking at how likely it is that the patient actually has T3 disease, or mostly T3A disease, so evidence of the cancer coming through the prostatic capsule based on radiomics features. Some also end up looking at how likely it is, based on radiomics features of the prostate, that the patient will actually be found to have distant metastatic disease with further imaging. I look at these as something that themselves are probably not entirely useful inherently, meaning I don't think that I will ever look at radiomics features of a prostate and then say, I don't need to do a bone scan or I don't need to do a PET scan. But I think that it really may be telling us something that may be inherently different about this cancer. This cancer looks different on our radiomics analysis, therefore there might be something inherently different about that cancer, which is more associated with having distant metastatic disease. And so here's just a representative publication looking at whether or not radiomics can end up predicting T3 disease. In this one, they ended up analyzing 119 patients who had a pre-treatment MRI. They only looked at T2 weighted imaging, and then all these patients ended up undergoing a radical prostatectomy. They would end up segmenting MR lesions that were near the capsule and then doing a radiomics analysis on that to determine whether or not it was likely that those patients were going to be found in final pathology to have extracapsular extension at that place. And what they found is that with a 17-feature radiomic signature, you actually had an area under the ROC curve of 0.82 to predict whether or not the patient would actually have T3 disease. Now, one significant issue with this publication, unfortunately, is the fact that they didn't actually take into account how many of these patients had clinically obvious extracapsular extension on their T2 weighted imaging. So in some of these MRIs, you can see that there's tumor coming through the capsule, in which case radiomics analysis isn't going to do anything for us. And so it's really somewhat unclear as to how helpful this really will end up being for us. And then another publication by Zhang et al. In July of this year ended up looking at the likelihood that radiomics features can end up predicting the likelihood that a patient will actually be found to have metastatic disease on either bone scan or PET scan. What they found is that with a radiomic signature, they can end up finding an area under the ROC curve of 0.84. So actually pretty decent predictability as far as whether or not the patient will have distant metastatic disease. But they also then compared it to regular clinical features, things like known T-stage Gleason score PSA, which it itself had an area under the ROC curve of the same, basically 0.85. So it doesn't look like radiomics necessarily is improving what we can already do, but it does end up, I think, again, giving us some idea that there might be something inherently different about those tumors that we are able to actually assess on imaging. Which I think is a good segue into the next topic, which is, that's all fine and well, but what the heck is radiomics actually teaching us? And unfortunately, at this point, most of radiomics is essentially a black box mechanism. We have all these fancy things that have names that we really can't comprehend what they are. And we can see that they end up correlating with something happening clinically. But does it actually have any sort of real bearing on what's happening at a tissue or cellular level? So there have been just a couple studies that have really looked at this. Really a singular study that looked at whether or not it predicts anything histologically, and another one that looked at whether or not it actually predicts anything from a genomic standpoint. So first off, with histology, there was a single paper that came out in PLOS 1 in 2018, and what they did is they tried to correlate a radiomic signature with something called quantitative histopathology, and they did it in 34 patients. Basically what they ended up doing is they extracted 157 features from T2 weighted MRIs when they only segmented the MRI lesion. They didn't do whole gland or whole peripheral zone. And then they ended up looking at the histology of the area after radical prostatectomy that correlated with that MRI lesion. Now, for the radiomics features, they would end up actually creating a radiomics signature that was really based on the ability to detect whether or not somebody has high or low Gleason score disease. And then they ended up correlating whether or not that ability to detect high Gleason score disease was associated with differences in the histology of that area. And what they found is that there were a total of 54 histologic features that correlated with radiomic signatures. And that a lot of them ended up being associated with things like small gland lumen diameter, heterogeneous lumen orientation, general smoothness in the histologic appearance, et cetera. Now, looking at this, I think that this is a very interesting study, but the other thing that's notable here is that gland appearance, gland heterogeneity, et cetera, is really what goes into how we define Gleason score in the first place. And so we really end up having a radiomic signature that was designed to determine whether or not somebody has a different Gleason score, and then we ended up confirming that yes, it determines whether or not they have a high or low Gleason score. And so again, I think that it's something that shows us that radiomics itself can end up showing us something at a tissue level, but again, it's still somewhat unclear as to whether or not it's better than what we're already doing. And then the next study looking at radiogenomics, this is something that I find absolutely fascinating, but it's a study that ended up coming out in 2016 where the authors ended up correlating 49 radiomics features from tumor and normal prostate across 17 biopsies from 6 patients. And basically what they ended up finding what they ended up doing is they ended up looking at radiomics features comparing the healthy or the benign versus malignant lesions, or malignant biopsies, I should say, and compared it to 3 pre-validated genomic signatures of cancer aggressiveness, specifically looking at Decipher score, cell cycle progression, and then the genomic prostate score. And what they found is that there was very significant correlation between radiomic signatures and what they end up finding, especially on Decipher score, specifically with genes known to affect immune response, metabolism, and cell adhesion. So I'm gonna skip our work because I only have 5 minutes left, but so this ends up going into also with this, there's a bit of unanswered questions with regards to radiomics. Now, if you look at the studies that I presented, most people end up looking at T2 weighted imaging, and then some will add ADC, some will add DCE, some will add DWI, et cetera. That's all fine and well, but the reality is that we don't know which of these imaging sequences is going to be our highest yield. And so for most of us doing radiomics research, we're essentially relegated to trying to extract features from all of them, in which case then we have so much data that it's really difficult to sort through. So that's number one. Number two is we don't even know what's the best imaging test to use. There are some people that are doing MRI, most people are doing MRI, but you can end up getting different features from things like CTs and PET scans as well that are at this point fairly underrepresented in the literature. Another question ends up being, when do we end up analyzing? So do we just do it at the time of diagnosis? Is that most important? Or is it actually more of a longitudinal change that we end up needing to look at here? For example, doing an MRI pre-treatment and then post-treatment, seeing differences and seeing if that actually correlates with outcomes better. And that's something that, again, it's actively being researched, but it's not something that we have a good understanding as to what the right answer is anymore. And then going into just the frank concerns about radiomics. And the biggest concern that we have with radiomics is reproducibility. And this is something that, is still something that we're all working on, trying to find ways to get around. But basically, here are 4 publications that have really looked at serial MRIs with no treatment in between. And, well, at least 3 of them had no treatment in between, and then look to see whether or not there's any consistency in radiomics features. The first, which was published in May of this year, ended up looking at 15 treatment-naive patients. They ended up having 2 multiparametric MRIs 2 weeks apart. And they ended up extracting 307 features from the whole glands of both of them. What they found is that only 18 of those features were actually reproducible, as in they had similar features between the 2 MRIs of the same patient with no treatment in between, just 2 weeks in between. And in reality, the concordance coefficient with that was still only 0.65. So it still wasn't great correlation. The second one ended up doing a very similar study. Again, 2 MRIs across 2 weeks. There was no interim treatment. They ended up segmenting both whole gland and peripheral zone, and then also ended up doing the MRI lesions as well. And regardless of how they tried to normalize, they couldn't find anything that was ultimately consistent across any of these sequences for these patients. And then one that went even further and actually ended up doing 2 MRIs on the same day, at least within the same 24-hour period, and looked at the same thing. And again, ended up having that there was some consistency across features, but that consistency really ranged from between 61 to 81% consistent, again, with 2 MRIs over the exact same day on the same scanner. And so this last paper ended up doing this in a little bit more problematic of a way, I think, but one of the points they ended up coming up with, I think, is something that's very important. So what they ended up doing is they ended up taking 2 MRIs, 1 pre-treatment and then 1 post-treatment, and all patients got radiation in between them. And so obviously something now has happened to their prostate glands, so the likelihood that you're going to have difference in radiomics features is high. But what they ended up concluding is that they couldn't find anything that was consistent between the two, which again isn't a huge surprise. But one thing that they ended up suggesting with this is that we really need to come up with some sort of basically consistent set of features that we use for a benchmark, similar to what we end up using with, say, actin for a Western blot, where we know that we're basically comparing apples to apples with all of our radiomics features so that we are actually able to understand what it is we're looking at here. And so in conclusion, radiomics is a promising and very rapidly expanding field in GU oncology, but there are still very many questions with regards to how to do it properly and what the real utility will end up being. And without some sort of universal standardization to allow for relative interpretation across image sets, both across imagers and then longitudinally within a patient, applicability is going to remain a bit murky with it.